Let's talk about the economics of AIDS. A problem affecting as many people as the AIDS virus is bound to be complicated and to have many different economic dimensions. Let's take a look at some. The Copenhagen Consensus is a project focusing on rational prioritization based on economic analysis. It argues that despite billions spent by the developed world, money spent on problems such as malnutrition and climate change is not sufficient to meet many internationally agreed upon targets. The project assigned the highest priority to addressing the spread of HIV and AIDS, and the economists there estimated that an investment of $27 billion could avert nearly 30 million new infections by 2010. It's not happening. It didn't happen. What are the economic costs of this failure? In Africa, they center on reduced labor supply. The HIV/AIDS pandemic has caused increased mortality and morbidity and the loss of skills in key sector of the labor market. In South Africa, 60% of the mining workforce is aged between 30 and 44 years. In 15 years, this is predicted to fall 10% due to death and dislocation from AIDS. In the South African healthcare sector, some 20% of student nurses are HIV positive. This also leads to a reduced labor productivity. AIDS kills slowly, and the long period of illness reduces labor productivity. One review reported that the annual costs associated with sickness and reduced productivity as a result of HIV/AIDS ranged from $170 per employee in a Kenyan car manufacturing firm to $300 in the Ugandan Railway Corporation. These costs reduce competitiveness and profits. Government incomes decline, tax revenues fall, and the governments are pressured to increase their spending to deal with the rising prevalence of AIDS, thereby contributing to fiscal crises. On African farms, the father dies, the children are taken from school, the mother dies, the father's productivity suffers, and families are severely disoriented and dislocated. In Africa, AIDS is hitting the middle classes and hitting them hard. There are significant losses among the class of educated managerial talent. One study showed that the rate of HIV infection increased with the seniority of position among skilled workers. The more disposable income, the more sexual activity, the greater the infection rate. But the most horrifying cost, perhaps, is that of the orphans. This terrible situation exhausts the state's resources, and orphans become maladjusted, disruptive forces in society. In 1990 in Uganda, one report estimated that 14% of kids lacked parents. The numbers are huge: 600,000 in Kenya, 700,000 in Tanzania, 900,000 in Uganda. Orphan girls lack dowries and are unattractive as mates. Boys have no skills or even basic literacy. Look at these two videos on YouTube to get some idea of the day-to-day reality of the chokoras, or the scavengers, in Kenya and the orphan crisis in Zimbabwe. Across Africa by 2010, there were over 20 million orphans. Many have lost cultural and social attachments to their world. They are easy to recruit into criminal gangs or as child soldiers in warring factions. The AIDS epidemic has also led to reduced exports and increased imports. The lower domestic productivity reduces exports and the money they bring, leaving less money for imports of expensive healthcare goods. The balance of payments between export earnings and import expenditure comes under pressure. Then government budgets come under pressure, and this causes defaults on debt repayments and requires economic assistance from the international community. It's all a vicious cycle. So, how did the big drug companies, big pharma, respond to the crisis at home in the U.S. and to the crisis abroad? These companies, by the late 1980s, were facing great pressure from the gay population in the U.S., a population desperate for solutions that seemed to them to be slow in coming. Many accused Big Pharma of slowness in acting, even of insensitivity to the problem, both at home in the U.S. and abroad. But let's explore this issue a little bit more deeply. The first effective drug was AZT. It helped to regenerate immune systems and block the virus. AZT was developed with public money in the public domain. The companies that developed the drug charged $10,000 per year for treatment, well beyond the means of most victims. This price stimulated public demonstrations, and the companies lowered the price. AZT, however, was not effective long-term because the virus adapted and developed resistance. More of the story lies in the process a new drug must undergo before it is deemed safe. All prescription pharmaceuticals in the U.S. have to go through a rigorous 8 to 10-year testing process. By 1985, the FDA testing standards were so strict that fewer than 1 in 5,000 molecules developed in pharma labs made it to the market. The cost for successful testing is extremely high and goes through 3 stages. 1, general safety, 2, doing and effectiveness, and 3, long-term effectiveness and safety compared to a placebo. After this process, only 1/3 are retained after the vast majority are already discarded. How did this happen? Why does it take so long? A quick look at history helps us understand. The FDA was established in 1906 with the Pure Food and Drug Act. Remember Upton Sinclair's novel, The Jungle? Its purpose was to make sure ingredients were listed honestly, but it had limited supervisory ability. 1937 saw a big change when the Massengill Drug Company dissolved sulfa drugs in antifreeze, attempting to make a formulation that would taste good to children. The product killed more than 100 before it was pulled from the shelves. Somewhat stricter supervision occurred until 1960, but now a second major change in the period came from 1958 to 1961. Thalidomide, a sedative drug, was prescribed to thousands in the U.S., including over 600 pregnant women, and the drug caused hundreds of severely deformed babies to be born. Now new legislation was passed, making the testing procedure much more rigorous. The drug industry in general was severely shaken by the thalidomide episode, and now the public was much better protected. But the scare created a highly conservative pharma industry, unwilling to bring new products to market unless huge profits could be guaranteed and safety ensured. But AIDS patients understandably blamed big drug companies for their failure to invest in research to cure AIDS. The system as it was ignored the needs of terminally ill patients, desperate for a cure, many of whom wanted to try non-approved formulations. One said, "It's as if I'm in a disabled airplane, speeding downward and out of control. I see a parachute hanging on the cabin wall, one small amount of hope. I try to strap it on when a government employee reaches out and tears it off my back, admonishing, 'You can't use that. It doesn't have a Federal Aviation Administration's inspection sticker on it. We don't know if it will work.'" But, withal, in retrospect, the response to the AIDS crisis in the U.S. was remarkably fast. Let's briefly compare it to polio. Polio was first documented as an epidemic in 1885, its agent isolated in 1949, and therapy available in 1953 with the Salk vaccine. In AIDS, the first documented epidemic was in 1981, the agent isolated in 1986, and triple combination therapies available in 1996. A remarkable achievement of the American medical establishment. But finding drugs is not the same as delivering them. HIV frequently mutates and is very resistant to drug therapy. In 1996, the creator of the so-called triple cocktail combination therapy, Dr. David Ho, was named Man of the Year by Time magazine. And in the U.S., the triple cocktail was widely available to patients with health insurance. Patients on the triple cocktail lived an average of 8 years longer than those without the therapy. But the problem, as always, was cost. The triple cocktail ran about $15,000 per year. This new problem was poignantly articulated by a Zambian woman at a conference in Vancouver where she said, "The breakthrough means nothing to me. I can't afford the drugs. I'm going to die anyway." What she was talking about was the morally insurmountable inequality of cost. In 1996, some 20 million Africans were infected, but how could they be treated? Big Pharma argued that the high cost of antiretroviral drugs was justified to fund further research. In the U.S., the drugs are priced at huge markups over manufacturing costs to recover development costs, and patents are protected for 20 years. Drug companies are reluctant to give up such control. Even still, many drug companies bowed to pressure, and by 2003, prices of drugs to developing countries came down to as low as $400, with Merck and Pfizer leading the way. Still, the problem persisted because even at that cost, drugs unaffordable to the poor and the developing world were being denied. African governments remained strapped for funds and unable to face the challenge of distribution. International aid stepped in to partially fill the gap. Jeffrey Sachs, the well-known economist, and Kofi Annan of the UN proposed a $4 billion fund to assist with the distribution of drugs. And in the U.S., the religious leader Franklin Graham called evangelicals together and called for church leadership against AIDS. And the Bush administration responded to the rock star Bono and to the conservative politician Jesse Helms, now an advocate of government support. In a State of the Union address, Bush asked Congress for $15 billion over 5 years to fight AIDS in Africa and in the Caribbean. It was a good start, but some problems persisted. The Bush plan emphasized abstinence over condoms. Brazil, for example, rejected the U.S. money because of such strings, such as refusal to include prostitutes and refusal to focus on condoms. The Gates Foundation pledged millions, and other charitable foundations stepped in, but the combination of reduced cost of medicine and international aid was still not enough to close the gap. South Africa was the recipient of a large amount of aid, but Thabo Mbeki, the president, had banned the triple cocktail. Activists sued in court, they won, and eventually the money flowed in, although late. Another area relating to economics and AIDS is, of course, blood and hemophiliacs. When AIDS came to the blood supply in the U.S., the blood bank industry was reluctant to admit that the blood supply was contaminated, since it faced huge potential economic loss. It came, however, to this realization too late, after 35,000 patients were infected by blood transfusions. Take a look at these two clips. The first deals with Ryan White's infection through a transfusion, and the second, a segment from And the Band Played On, deals with the CDC and blood contamination. Another aspect of AIDS and its economic dimensions is blood and the poor. The poor in the developing world donate blood at $10 per pint, and poverty is the context for the spread of HIV. The first documented case of the epidemic among blood donors was in a poor suburb of Mexico City in 1986. More than 250 donors were found to be HIV positive. These people, economically desperate, often sold plasma 10 times per month, and there were 13 plasma donation centers in and around Mexico City. Most of the donors were young men, sometimes allowed to sell their blood every 2 or 3 days. By 1987, 7% of more than 9,000 donors were infected. There were other outbreaks among poor donors in Spain and India, with the reuse of blood collection material blamed. In some poor areas, death came quickly. In Pune, India, HIV prevalence was 0% in 1987, then an astonishing 78% only 7 months later. Incredibly fast transmission. These outbreaks were tragic, but they are dwarfed by what happened in China in the early 1990s. In rural areas, poor farmers were recruited by plasma pimps to supplement their income. Donors received $6 per donation and in theory repeated twice per month, but often donors went to multiple donation centers. Blood product companies set up hundreds of stations. The most effective provinces were Anhui, Henan, Shanxi, Hubei, and Shandong, where about 250,000 donors contracted the virus. In some cases, the blood from the donors with the same blood type was actually combined for more efficient plasma separation, then returned to donors along with the infection. No donors, of course, had been initially screened for HIV. This process, of course, was also marred by the reuse of needles and tubing. Some 17% of all plasma donors were infected. In India, Spain, Haiti, Mexico, and China, all the same story. The desperate poor, willing to sell blood repeatedly, profit-driven blood collection centers, and a small number of entrepreneurs cutting costs wherever possible, reusing equipment, and a patient zero to introduce the virus. Much of this plasma or blood in the 1970s and early 1980s was sold by the developing world to the industrialized West. Any virus present could travel thousands of miles in all directions, ending in the veins of many recipients. The intersection of AIDS and capitalism. was often cruel indeed.